Hi, I'm Dr. Duke, and this is I'm Right. Today, I am really thrilled to be joined with Dr. Kishore. Dr. Kishore is a bit of a legend in this country, and one that more people need to know about. Doc, you have come up with a wonderful way to treat opioid addiction. You used to have a clinic that did incredible things before the federal government got jealous of your success and came after you. And in later segments, we're going to get a lot more into that. I think the American people need to know exactly how your successful treatment of opioid addiction became a problem for the feds. We'll get to that. But before I do, tell us a little bit, Doc, what you're doing now. Tell us about your institute and how people can get a hold of you if they have questions.
I'm a physician specializing in drug and alcohol addiction, and I've been doing it for 40 years, and I've successfully practiced in Massachusetts for all these years. And currently I'm running a company called National Library of Health and Healing, situated in Waldoboro, Maine, Fairmont, New Hampshire, Manchester, and in Boston. And we educate people on the dangers of opioids and how to get help.
So the National Library of Health and Healing, by all means, look that up online. You're going to get a lot of great information. Now, Dr. Kishore, the thing that you are most reputed for, and if the government had this is the American government, by the way, who sort of forced you out of business because you were too effective. You were doing an end run around insurance companies. You were doing an end run around government-sponsored programs. You were healing people with addiction. Talk briefly a little bit about the nature of the opioid crisis in this country, and then I'll give you a chance to talk about your solution. Tell us a little bit about what's going on in this country with opioid medicines.
Right now, we have a national emergency declared by President Trump right now. We are in the middle of a crisis here. We have 65,000 people who died last year in 2016-17 from opioid overdoses, which is more than all the people who died in the Vietnam War. So we are in the midst of the major catastrophe here. The drug deaths have been going up exponentially every year, and there seems to be no end for the epidemic right now. The problem essentially is we are using wrong technique. Addiction is a disease that needs to be segregated, not aggregated together in one place. This infectious disease, in a way, if you want to call it a disease, more like an infectious disease, where you have to treat each person individually. And the current policies call for people to be corralled in clinics and rehab centers and places like prisons and other places where they're putting everybody together and creating a massive problem of cross-contamination of ideas, cross-contamination of behaviors, cross-contamination of approaches, resulting in a major problem here. So we have to go back to look at why this whole thing started. It goes back to the Civil War in 1862, when we brought morphine to treat the Civil War soldiers. And we gave them needles and a flask of morphine to inject themselves. And this was the start of the whole epidemic that we are seeing now. We have tried various techniques. In 1914, we tried to legislate it out of the country by passing the Harrison's Narcotic Act. It worked in a way, but it did not work. The needle use continued till the 60s, and then once again it began to expand exponentially. To control the epidemic of heroin use, we brought in methadone, which didn't help at all. Just like heroin did not help with morphine addiction, methadone did not help with heroin addiction. So it basically fits the definition of insanity, repeating the same thing again and again, even though you're not getting the desired results. So that's part of the problem is policy issues. We've got a situation where we are promoting policies that don't work. Right now, the cornerstones for treatment are methadone, Suboxone, Vivitrol, and Narcan. The four drugs form the basis for the opioids. But unfortunately, addiction is not just an individual disease, but a family disease, a community disease, and it has to be approached in that order. We have to go to the families. And this is where the policy is a failure. We are not giving any importance to the families. We are isolating the addicts and segregating them into rehab centers, detox centers, and creating a massive problem. Once they come out, they're not just addicts, but they're all addicts on with a lot of new information about where to get the drug, how to score the drug, how to get to the drug trade. So we have a situation that is exponentially growing, and we need to do something drastically different, which is to go back to the basics. Go back to treating the addicted person in their own communities and in their own homes, and and not transport them across the state boundaries. That's number one, how to treat. Number two, we have to cut back the supplies. How do you cut back the supplies? We can cut back the demand by treating the addict and helping them get back into the mainstream of life, jobs, workforce, so on and so forth. But then how do you cut down the supply? We have to control our borders. Without any kind of a border control, the drugs are coming in freely from across Mexico, from China through the port cities, Vancouver, South Boston, you name it. All the ports are becoming the entry points for massive amounts of fentanyl made in China. If we don't stop that, no matter what we do at the individual level, it'll fail. And the third thing is we have to have sensible policies where we support the families to live happily, healthily in their own communities without having to send their kids away to some faraway places. So it's the three angles of the triangle. We got to reduce the supplies. We got to strengthen the individuals. We're going to strengthen the communities. Unless we take a three-pronged approach, we will not get the results we desire.
Now, Dr. Kishore, wonderfully phrased. We've got three different triangle points. And what I am most amazed about is that not one of them has anything to do with administering further medication. When you're treating patients, you get the community, you get the family involved, you get the community aspect going. When you're actually treating these patients, do you have any kind of a medical balance or fix for them? Or is this purely a matter of getting them off of these drugs without any other synthetic remedies?
We do not need any synthetic remedies. For the vast majority of the people can get sober, stay sober, and move on with life. The addiction has four components. Number one is the withdrawal itself. Coming off the drug. Getting on the drug is easy. Coming off the drug is very hard. And this is what the addict dreads most, how to come off the stuff. Everybody wants to come off the stuff, but how do you do it? It's pretty easy. You got to have an analytical mind. The withdrawal syndrome is actually consists of five components. Number one, they lose control on their gut. They throw up as well as they have diarrhea. Number two, they lose control on their neuromuscular system. The muscles become stiff like a board. Number three, they lose control on their hypertension, blood pressure control. They get what they call the heebie-jeebies or hot and cold feelings, and they don't feel right. Number four, they can't sleep. They stay awake all night. Number five, they don't have the will and wherewithal to conduct life. To conduct life, you must have executive functions. You must say, okay, I'm going to meet this person at 1 o'clock. I'm going to be there 5 minutes to 1. They cannot execute partially because the body is depleted of nutrients. So number one, to take care of the nausea and vomiting, we can do it with a shot of Zofran, a medicine that we give for cancer chemotherapy. Number two, to control the muscular system, we can control it with baclofen, a medicine we give for MS, where the stiffness of the muscles also. Number three, we can control the hypertension fluctuations by a simple patch that's good for 7 days, called clonidine. Number four, they can't sleep. If you initiate the sleep, they fall asleep. So that's easy to do with the 10 milligrams of doxypen. And as to the feeling mopey or listless or unable to conduct life, we can give them mineral and vitamin solutions that get them to have the get-go to do things on a daily basis. All of these vitamins are depleted during the process of detoxifying. The body tries to detoxify the methadone or heroin or whatever it is. The body loses all his vitamin supplies. Plus, the nutrition is not good. If we get that into balance, well, we achieved a first goal, which is to control the withdrawal syndrome. It's a 5-day process. It's a 3 to 5 day process. It can be done by a primary care doctor in his own office. Hook up a little IV, give them some medicines, give them a shot, and send them home, bring them back. You can do it in 3 to 5 days. The normal cost of a detox is $10,000 for 3 to 5 days. We can do that with less than $500.
Mm.
So once you get the detox done, the next step is this can be done by any primary care doctor in the country. We don't have to go a specialist or a rehab center. It can be done very easily by any doctor with some common sense. Number two, to control the relapse. And the second problem is a relapse. Every stone you throw into the sky comes down. Every addict will relapse unless you do certain things. The relapse happens because of craving. If they have cravings for the drug, even though they're sober, doing well, they think about the drug. They think about it. They have to act on it. They have loss of control. Once they have loss of control, they have consequences. And then the whole rigmarole starts all over again. To prevent that, we got to take away the craving. There is a medicine for cravings called Vivitrol, which will take away the cravings in 30 seconds flat. You give it to them for a month or 2 or 3, then they lose the cravings or the desire for the drug, and then they focus on other things in life. Now, once you get the sobriety maintained, we have tons of money we're investing in methadone maintenance. Similarly, we should invest a little bit of money in sobriety maintenance to maintain the sobriety of a person's life. Now, we've got to create life-enhancing experiences. When people are addicted, they do bad things. They steal, they rob, they cheat, they connive. This is all part of the addict lifestyle. But now, once they're sobered up, they got to exorcise these behaviors from their lifestyle. To do that, you need to enhance the sobriety experience by bringing in pastoral community into the fold. If they get involved with the church or spiritual aspects of life, if they have a job and a hobby, they don't relapse. We saw that again and again and again with our patients. So we have to connect the community together in a healthy way. So this person is sober. Let's see what's the church in this area, or a Bible school, or a college we can send the person to. And once they are in that mode of thinking, they don't want to go back.
Dr. Kishore, I want you to finish those final two statements, and then I want you to. I'm just blown away how common sense this all is. How inexpensive, how common sense, how you don't need specialists, you don't need clinics, you don't need different variants of morphine. You don't need any of it. Take a second and give me the last 2 points you were making, and then as we wind down in the last minute or so, tell me and tell us why. Why is something so common sense and obvious? Why is there so much resistance to it in the medical community and in the government?
Well, all this can be done through primary care. Primary care is the cheapest way to do it. The pecking order for reimbursement is $400 for a psych doctor to see a patient. For a primary care doctor, it's $90 or even less. So we can easily achieve our goals of keeping people sober, getting communities healthy through a primary care doctors. We need primary care doctors who have a smaller significant interest in addictions. The reason why this common sense is uncommon, we have vested a ton of money in institutions like Taj Mahal. So we invested a lot of money in detox centers, methadone clinics, Suboxone clinics. We have prisons that are doing rehab. All of this is about $80 to $100 billion enterprise every year. When you convert the addiction treatment into primary care, it'll cheapen it like no tomorrow. So there is a bit of a fear that this model will take root. It already took root in Massachusetts. We have 52 centers. We went into every community in Massachusetts because the mayors wanted it, the community stakeholders wanted it. It's not because I wanted to set up a clinic. I'm pretty happy with one clinic. But the communities needed the care in their own communities so that they can easily step in, step out of the office. So we created a model that's been nationally recognized as the Massachusetts model. It is in contrast to the 3 other models. The Minnesota model, which is a 28-day rehab spa treatment for $30,000. Then you have the Florida model, which is Minnesota Light, where you stay in a hotel or a motel instead of in a big spa, and you pay $10,000 a month for 3 months. And then you have the Pennsylvania model, which is what the current model is, which is medication-assisted therapy or medication replacement therapy. Addicts are the fundamental paradigm is the addicts are bad people. They're incorrigible. Give them what they want. Give them instead of illegal drug, give them a legal drug, and keep them under control. This is the Pennsylvania model. And the 4th model is a holistic model, a whole person approach. treat the whole person, get the withdrawal away in 3 to 5 days, cut the umbilical cord, and then restore them back to life. Not just rehab, but restoring the person back to where they were is the key mantra here. We have to have that. And
so the holistic model is exactly right. That's your model. And it sounds like the only real viable solution. It's cheaper, it's more cost effective, it's safest, it's healthiest. As we wind down here, Dr. Kishore, give the audience, and we'll have you back to talk more specifically about your method. You gave us a great overview here today, but tell the audience where they can find out more about your holistic method until we're able to talk again.
Well, in a Google search, if they Google search a Massachusetts model and put my name, Dr. Kishore, the whole model pops up. The presentation I did in Albuquerque, New Mexico, at the National Institute of Drug Abuse will pop up. There are different websites with my name, Punyamurtulakishore.org, or the preventivemedicineassociates.com. All these websites are interconnected, so if they just research my name, it'll come up.
We'll be in touch soon, Doc. This is a great story. We want to get the rest of your story out. We'll be in touch soon. Thank you very much for being here today. If you enjoyed that video, please consider following us online and also consider a tax-deductible donation so we can continue to produce quality videos like the one you just watched. I'm Dr. Duke. Thanks for watching.